Here's my approach to chronic cough. Chronic cough is common and is defined as a persistent cough lasting more than 8 weeks in adults. Although chronic cough in adults has many potential causes, 5 conditions account for the majority of cases, like upper airway cough syndrome, GERD or laryngopharyngeal reflux, ACE inhibitor-related cough, asthma, and non-asthmatic eosinophilic bronchitis. When evaluating a patient or clinical vignette with cough as a primary complaint, be sure to ask about the duration. If it exceeds 8 weeks, consider chronic cough in your differential diagnosis. A 42-year-old woman presents to the clinic with a 10-week history of persistent dry cough. She denies fever, chest pain, dyspnea, or hemoptysis. She reports that the cough is worse at night and in the early morning. She also complains of frequent throat clearing and a sensation of something dripping in the back of her throat. She does not smoke and has no history of asthma. Physical examination is normal, except for mild cobblestoning of the posterior pharynx. Pulmonary examination is clear to auscultation. Chest x-ray obtained last week was normal. Which of the following is the most likely cause of this patient's symptoms? Asthma, GERD, chronic bronchitis, upper airway cough syndrome, or ACE inhibitor-induced cough? The correct answer is D, upper airway cough syndrome. This patient presents with a chronic non-productive cough lasting over 8 weeks, worse at night, and associated with postnasal drip symptoms like throat clearing or sensation of drainage. The presence of posterior pharyngeal cobblestoning and the normal chest x-ray further supports upper airway cough syndrome, formerly known as postnasal drip syndrome, as the most likely cause. Upper airway cough syndrome, again formerly known as postnasal drip syndrome, is the most common cause of chronic cough in the United States. Rhinorrhea, nasal congestion, sneezing, itching, and postnasal drainage are suggestive of this diagnosis, though their absence does not exclude the diagnosis. Physical exam findings may include swollen turbinates, visible postnasal drainage, and cobblestoning of the posterior pharynx. A 45-year-old man presents with a persistent dry cough for the past 2 months. He describes a sensation of something dripping in the back of his throat and frequent throat clearing, especially at night. He denies wheezing, fever, shortness of breath, or heartburn. He has a history of seasonal allergic rhinitis. He does not smoke. Lungs are clear to auscultation, and a chest x-ray performed 2 weeks ago was normal. Which of the following is the most appropriate next step in management? A. Start a PPI. B. Begin inhaled bronchodilator therapy. C. Perform a bronchoscopy. D. Prescribe an intranasal steroid. Or E. Order 24-hour esophageal pH monitoring. The correct answer is D. Prescribe an intranasal steroid. This patient's presentation is again consistent with upper airway cough syndrome, as suggested by postnasal drip symptoms, a normal lung exam, and absence of systemic findings. Initiation of intranasal steroids is an appropriate next step in management. For chronic allergic rhinitis, the main treatment is nasal steroids or second or third generation antihistamines. For chronic non-allergic rhinitis, as well as chronic rhinosinusitis, the main treatment is first generation antihistamine plus decongestants like Sudafed. Here's a 40-year-old woman presents to the clinic with a non-productive cough that has persisted over the past 3 months. The cough is worse at night and sometimes wakes her from sleep. She denies fever, dyspnea, wheezing, or sputum production. She also reports a sour taste in her mouth when laying down and occasional hoarseness. She does not smoke, and her only medication is a daily multivitamin. Physical examination, including pulmonary and cardiac exams, are both unremarkable. A chest x-ray performed 2 weeks ago was normal. Which of the following is the most likely cause of this patient's chronic cough? Upper airway cough syndrome, asthma, GERD, chronic bronchitis, or medication side effect? The correct answer is C, gastroesophageal reflux disease. This patient presents with a chronic cough, again, by definition, more than 8 weeks. that is worse at night and associated with the classic GERD symptoms like sour taste, worsening with recumbency, and hoarseness. GERD is one of the three most common causes of chronic cough, alongside asthma and upper airway cough syndrome. The hallmark symptoms of GERD are heartburn and regurgitation. Extraesophageal manifestations can also include chest pain, chronic cough, hoarseness, and wheezing. In the absence of alarms features like anemia, dysphagia, persistent vomiting, or weight loss, a trial of a proton pump inhibitor therapy can serve both diagnostic as well as therapeutic purposes. Patients with GERD symptoms and without any alarming symptoms may try 8 weeks of PPI plus lifestyle modification. PPIs are first-line therapy for GERD as well as GERD with extraesophageal manifestations, including those with asthma, laryngitis, and chronic cough. A 60-year-old man presents to the clinic with a persistent dry cough that has lasted for 10 weeks. The cough is non productive, occurs throughout the day, and is not associated with wheezing, postnasal drip, fever, or heartburn. He denies smoking. His past medical history includes hypertension and type 2 diabetes. His medications include lisinopril, metformin, and atorvastatin. Physical examinations are remarkable, and recent chest x-ray is normal. Which of the following is the most likely cause of this patient's chronic cough? Asthma, GERD, ACE inhibitor induced cough, upper airway cough syndrome, or chronic bronchitis? The correct answer is C, ACE inhibitor induced cough. This patient presents with a chronic dry cough lasting 8 weeks in the absence of infection, smoking, or pulmonary findings. He is taking lisinopril, an ACE inhibitor, which is a well-known cause of chronic dry cough in up to 10% of patients. The mechanism is thought to be related to bradykinin accumulation. The onset of ACE inhibitor-induced cough ranges from within hours of the first dose to even months after the initiation of therapy. The recommendation is to stop the ACE inhibitor, and the resolution is usually 1 to 4 weeks. A good substitute is an ARB. A 34-year-old male presents with a persistent dry cough that has lasted for the past 10 weeks. The cough is worse at night and with exercise. He denies fever, wheezing, chest pain, or post-nasal drip. He has no history of smoking. He has no other medical conditions and takes no daily medications. Physical examination, including chest auscultation, unremarkable. A chest x-ray, normal. He was previously treated with a short course of antibiotics and antihistamines without improvement. Which of the following is the most likely cause of his symptoms? GERD, upper airway cough syndrome, chronic bronchitis, cough variant asthma, or ACE inhibitor induced cough? The correct answer is D, cough variant asthma. This patient presents with an isolated chronic dry cough, especially worse at night and with exertion, which is characteristic of cough variant asthma, which is a subtype of asthma that presents without classic wheezing or dyspnea. It's one of the top three causes of chronic cough in the US, along with GERD and upper airway cough syndrome. Asthma typically presents with intermittent symptoms such as cough, wheezing, chest tightness, and shortness of breath. The cardinal features include reversible airway obstruction, airway inflammation, and hyperresponsiveness. Diagnostic evaluation begins with spirometry before and after bronchodilator administration. An improvement in FEV1 or FVC or both following bronchodilator use confirms reversible airflow obstruction. Pulmonary function testing is recommended for patients with atypical presentations like chronic cough. Bronchial challenge testing, such as methacholine challenge testing, is indicated when the clinical history is suggestive of asthma, but the baseline spirometry is normal. A 42-year-old female presents with an 11-week history of dry, persistent cough. She denies wheezing, dyspnea, chest pain, postnasal drip, or gastroesophageal reflux symptoms. She is a non-smoker and has no known allergies. She was previously treated empirically with a first-generation antihistamine with decongestant combination. followed by a PPI with no improvement. Chest x-ray, normal. Pulmonary function testing shows normal spirometry and no evidence of bronchial hyperresponsiveness on the metacholine challenge test. Sputum cytology reveals an elevated eosinophilic count. Which of the following is the most likely diagnosis? Asthma, GERD, upper airway cough syndrome, non-asthmatic eosinophilic bronchitis, or chronic bronchitis? The correct answer is D, non-asthmatic eosinophilic bronchitis. This patient has chronic cough without systemic symptoms and no improvement with empiric treatment for upper airway cough syndrome or GERD. Their normal spirometry and negative metacolon challenge effectively rules out the classic asthma, but the presence of eosinophils in sputum suggests eosinophilic airway inflammation. These findings are characteristic of non-asthmatic eosinophilic bronchitis, a common but under-recognized cause of chronic cough. A 42-year-old female presents for a follow-up of a chronic cough lasting nearly 3 months. She has no dyspnea, wheezing, or reflux symptoms. Previous trials of first-generation antihistamine with decongestant and a PPI provided no relief. Chest x-ray and spirometry are both normal. Metacolon challenge testing, negative. Sputum cytology shows significant eosinophilia. Which of the following is the most appropriate next step in management? Begin Montelukast, begin inhaled corticosteroid therapy, prescribe a short course of oral antibiotics, refer for bronchoscopy, or repeat metacolon challenge in 6 weeks. The correct answer is begin inhaled corticosteroid therapy. This patient meets the criteria for non-asthmatic eosinophilic bronchitis. The first-line treatment is inhaled corticosteroids, which reduce eosinophilic inflammation and improve symptoms in most patients. Montelukast may be used for eosinophilic airway conditions, but inhaled corticosteroid is more effective in this disease. Antibiotics are not indicated in the absence of infection. Bronchoscopy is reserved for unclear and refractory cases, and repeating the metacolon challenge test is not needed, as it has already ruled out asthma. Thank you, and that's my approach to chronic cough.